Hi, nice to meet you. I'm Laura Baum. I'm from Yale, and as she mentioned, I'll be talking about rectal cancer. So I have no disclosures, and we have 20 minutes for the talk today. Could you show the notes from the slide I'm on rather than from the next slide? Thank you. Okay, so first I want to emphasize that in locally advanced rectal cancer, our goal is always to maximize cure first, but the long-term morbidity with rectal cancer treatment, neuropathy, low anterior resection syndrome, APR with colostomy are real. And people will tolerate these outcomes in order to live longer and achieve a cure. But how can we cure as many people as possible first, while thinking along the way about minimizing morbidity? That is where the field is now, and that's what we're talking about with total neoadjuvant therapy. In the last 20 years or so, we've had similar rates of cure, not a lot of new drugs or novel therapy in the majority of patients, obviously with some exceptions, such as MSI-high. But what has TNT done? Generally, total neoadjuvant therapy has improved morbidity, maybe some small benefits in other outcomes, without a major paradigm shift in cure rates. So as background, rectal cancer staging up front is important for determining best candidates for curative intent treatment generally, and for total neoadjuvant treatment specifically. This is critical as earlier stage rectal cancer, specifically T1 to 2 and 0 disease, can often be treated without chemotherapy at all. And furthermore, complete staging in rectal cancer is crucial for identifying stage 4 oligometastatic disease who may be eligible for curative intent therapy, as that will also change management decision-making around surgery, radiation, and chemotherapy. Finally, MSI testing for mismatch repair deficiency, MRD deficient mismatch repair patients, is important as neoadjuvant therapies are evolving in this space, and this may impact about 5% or so of patients. Everything we discussed today is within NCCN guidelines, which have identified TNT as their preferred regimen for locally advanced rectal cancer. Okay, so practically speaking, what is total neoadjuvant therapy and why utilize it? So TNT is associated with increased compliance with chemotherapy due to greater tolerability early on in the treatment regimen, improved local control leading to less morbid surgeries, shorter time with ostomy based on the time course, and the ability to consider non-operative management in select patients. However, it can also be challenging to implement as there are multiple options represented in the studies, which we'll go into, with no clear best practice for chemotherapy regimen, e.g. FOLFOX or FOLFIRINOX, radiation doses of short or long course chemoradiotherapy, and sequencing of the chemo and XRT preoperatively. Treatment of rectal cancer requires a high level of coordination between medical oncology, radiation oncology, and surgical oncology to pull off this sequenced approach. And there's a continuing changing landscape of both immunotherapy in MSI-high patients, as well as watch and wait options for surgical options for patients with a past CR, with a clinical CR. So the standard surgical technique for resection of a rectal cancer is total mesorectal excision. This is removal of the entire mesorectum bounded by the mesorectal fascia. That is called the circumferential resection margin, the outer boundary of the excision. It's also called the lateral or radial margin. And patients with involvement of that circumferential resection margin have worse disease-free and overall survival. So the TME is the surgical margin. It's the surgical technique. The anatomic level, the type of surgery itself, is an LAR or an APR. One of the goals of total neoadjuvant therapy is thus to improve surgical outcomes like CRM involvement and morbidity through local control with radiation, as well as to get chemotherapy in up front with good adherence, which can theoretically also improve distant failure as well as local control. Okay, so here's what we know so far. The landmark 2004 SOUR study showed improvement in local control and reduced toxicity, but no change in overall survival with neoadjuvant chemoradiotherapy prior to surgery. The 2016 Polish 2 study, which does not use a current regimen for combined chemoradiation, also shows the feasibility of neoadjuvant approaches, also with equivalent long-term overall survival. Subsequently, the Stellar and Rapido trials both examined short-course radiotherapy and neoadjuvant chemotherapy prior to TME compared to long-course radiation, surgery, and adjuvant chemo. Protege 23 looks at chemointensification with FOLFIRINOX, surprisingly not FOLFOXIRI, heard the last talk, compared to traditional chemoradiotherapy. The OPRA, the recent OPRA trial, looks at watch and wait in patients in both arms treated with total neoadjuvant therapy. And finally, the last trial we'll look at briefly is the Sloan Kettering trial looking at neoadjuvant immunotherapy and watch and wait in patients with deficient MMR. So let's discuss these trials. Side by side, you can see the outcomes here for these TNT trials. We're not specified. The chemo here is a 5-FU oxaliplatin doublet regimen and was generally used for a total of about 4 months in most studies. It was similar but not uniform across trials, and the patient populations here are also not uniform. For example, Rapido focuses on high-risk patients with clinical T4 or N2 disease. Again, Stellar, Rapido, and Polish 2 all use short-course radiation in the experimental arms. In Rapido, adjuvant chemotherapy was optional. In Stellar, about 25% of both arms of the trial did not receive any adjuvant therapy, which means that that standard of care CRT TME chemo arm does not receive any effective systemic chemotherapy in about 25% of patients. Okay, so what do we see? Survival is similar across studies at 3 years for disease-free survival and overall survival. But what do we see that is different here? So in Stellar, we see overall survival improvement with TNT. It's the only trial that has shown this, keeping in mind that 25% of those standard of care patients did not receive any systemic dual agent chemotherapy. And the takeaway from Rapido was that disease-related treatment failure from distant METs was reduced with TNT, but there was no difference shown at 3 years in overall survival. Okay, here is the protocol for Protege 23. Similar to other trials, standard of care is CRT, combined radiation and chemotherapy with capecitabine for 5 weeks, followed by TME surgery, followed by adjuvant chemotherapy with a doublet regimen of FOLFOX. However, here the intervention arm was total neoadjuvant therapy with FOLFIRINOX for 3 months and long-course chemoradiation with capecitabine, and then surgery, and then an additional 3 months of adjuvant FOLFOX. Here are the results for Protege 23. We see an improvement in disease-free survival from 69 to 76%. We see a pass-CR of 28% rather than 12%. But because of the study design, we don't know if these outcomes represent intensification to FOLFIRINOX or the sequencing benefits of TNT. Furthermore, pass-CR is not a surrogate here for disease-free survival or overall survival and may reflect more the timing of radiation and chemotherapy preoperatively, as we know that time between radiation to surgery allows for higher pass-CR. For example, the Stellar trial, which also showed a similar improvement in pass-CR, did not, from 13 to 21%, did not include chemointensification. And here, finally, on these TNT trials, is the study designed for the OPRA trial. This is interesting. It's a study to look at the feasibility of watch and wait in patients treated with TNT with long-course radiation. You can see here that both arms of the trial are total neoadjuvant therapy arms with chemotherapy with FOLFOX in both arms. And again, you see the results from the OPRA trial. Disease-free survival is 75%. Comparable to historic controls and not different between arms. This graph for the OPRA trial shows TME-free survival by intention to treat. Those labels mean induction chemotherapy followed by chemoradiotherapy, and chemoradiotherapy followed by consolidation chemotherapy. It's the sequence of radiation and chemotherapy in the neoadjuvant setting. And the time interval from the end of chemoradiation to tumor restaging is longer in the radiation first group compared to the chemotherapy group by study design, allowing more time for the radiation to work, as tumor restaging took place about 8 weeks following TNT. So OPRA shows about 50% of patients have organ preservation at 3 years after total neoadjuvant treatment using a watch and wait strategy. And a confirmation of this finding by a phase 3 trial would provide really robust evidence favoring TNT of either sequence, even without the benefit of overall survival, because obviously the avoidance of surgery is a meaningful improvement in quality of life. So finally, to touch on the newest immunotherapy trial, the majority of patients with rectal cancer that is dMMR have Lynch syndromes, and these tumors are chemoresistant with a lack of response to 5-FU alone, and there's estimated to be a roughly 25% chance of progression on neoadjuvant therapy in these patients. We know that dMMR CRC may be responsive to immune checkpoint blockade, and the early results of the 2022 trial of dostarlimab, which is an anti-PD-1, showed 14 out of 14 complete response with no recurrent tumor at follow-up thus far. This picture shows the impressive clinical response on one patient on study with complete resolution of the tumor on imaging and visual exam at 6 months. But we do not yet have long-term data. So why did the hipster burn his mouth on his coffee? Because he drank it before it was cool. Okay, so just a few discussions about, wait, I forgot what I was going to say. Yeah, so just a few discussions on remaining areas of controversy and review what we just discussed in the context of the community. So we reviewed that TNT is for patients who will require chemotherapy and radiation. In theory, it can be used to improve surgical outcomes and have sphincter-sparing approaches over an APR, and this needs to be individualized. Regarding chemo, we discussed FOLFOX and FOLFIRINOX. You need to consider patient factors, performance status, disease status. Patients with involved CRM may benefit from escalated chemo. Younger patients may have a higher prevalence of pathology that is poorly responsive to standard chemotherapy, such as signet ring cell cancers or poorly differentiated mucinous cancers. And then finally, for stage 4 patients, this is an ongoing area of controversy given potential liver toxicity from irinotecan prior to liver-directed therapies versus a need for more aggressive treatment in higher risk disease. For radiation, short course is not recommended for T4 disease per NCCN or for any disease with threatened local control. There's also concern for lack of equivalence in low-lying or distal disease. On the other hand, several trials, including 3 that we reviewed here today, utilize short course radiotherapy and TNT with good efficacy. And then for stage 4 patients, it's a more complicated question again because short course may have an advantage over the long course in avoiding the 5+ weeks off of dual agent chemotherapy prior to definitive management of the metastatic disease. And then there's ongoing discussion of surgical approach, including addressing the liver prior to addressing local control in order to minimize this risk of sort of untreated metastatic disease. So that will be a conversation with surgical oncology and colorectal surgery as well. There's no standard best option for sequencing, either, like I mentioned, of metastatic surgical discussions or chemotherapy and chemoradiation and TNT. But when giving initial chemotherapy first, it's important to realize that something like 10% of patients, more like 25 or 30% of MSI-high patients will be chemo-resistant. And so if giving initial chemotherapy, short interval, e.g. 3 to 4 cycles of chemotherapy, 2 months or so, is needed to look for early progressors in patients potentially with chemotherapy-resistant disease. And finally, for MSI-high patients, neoadjuvant immunotherapy is likely to be incorporated into guidelines soon. You'll remember my joke. But as we know, patients are very interested in this approach as well, and many of these tumors are chemotherapy resistant. So while there's no long-term data in this space, obviously it's an area for greater discussion. Finally, surgery. Non-operative management is an evolving strategy. Patient selection is key, and I think it's important that this be done in a high-volume rectal cancer center where the surgeons are comfortable with non-operative management. TNT is critical to using watch and wait, but so is having a really guaranteed surveillance program. So in summary, the benefits of TNT primarily reflect improvements in quality of life and survivorship, such as less time with ostomy and more opportunity for an LAR rather than an APR, for watch and wait with past CR. But TNT also may improve adherence to chemotherapy, as chemotherapy is given earlier in the course of treatment with higher compliance, which in theory could also improve distant metastatic-free survival or overall survival with more long-term data, which we don't have yet. So references. I'd like to thank especially Michael Cicchini, who assisted me with a couple of these slides, and Jill Lacey and Ira Leeds, who reviewed these from a medical oncology and surgical perspective. And then, okay, so a 63-year-old man underwent colonoscopy for bright red blood per rectum and is found to have a tumor 8 centimeters from the anal verge. Pelvic MRI shows clinical T2N1 rectal tumor. CT chest, abdomen, and pelvis is negative for metastatic disease. Pathology shows moderately to poorly differentiated adenocarcinoma. He is deficient in MMR with a loss of MLH1 and PMS2 expression, and his MLH1 gene promoter is not methylated. Which approach is not a preferred approach with NCCN guidelines for treatment of his stage 3A MSI-high rectal cancer? A, short course radiation, 5x5, doublet FOLFOX for 4 months, and transabdominal resection. B, FOLFOX for 4 months, long course chemoradiation with capecitabine, transabdominal resection. C, long course chemoradiation, transabdominal resection, and adjuvant FOLFOX for 4 months. D, dostarlimab, 500 milligrams every 3 weeks for 6 months, and to watch and wait surveillance. So the correct answer is E, C, and D. C represents the traditional neoadjuvant chemoradiotherapy approach, followed by surgery and adjuvant chemotherapy. This is within guidelines, but is no longer preferred. And D, while promising, this is not yet incorporated into guidelines for neoadjuvant immunotherapy, is not yet incorporated into guidelines for neoadjuvant or adjuvant therapy for locally advanced rectal cancer. Okay, I have 1 minute and a half. So CME question 2, 63-year-old woman presents with sepsis to the emergency department and is found to have a perforated rectosigmoid tumor, T4A, which is below the peritoneal reflection with matted lymph nodes, N2B, and no metastatic disease. She has a dMMR intact, moderate to poorly differentiated adenocarcinoma. So that's stage 3C disease. She's fairly high risk. What is the preferred approach? A, short course radiation, neoadjuvant chemotherapy, resection. B, neoadjuvant chemotherapy, long course chemoradiation, resection. C, long course chemoradiation, surgery, adjuvant chemotherapy. D, treat as colon cancer given rectosigmoid location. And then E, the 2 TNT regimens. Everybody think. Okay. The correct answer is B. This represents TNT with long course chemoradiation. A is incorrect because short course radiation is not generally recommended for T4 or bulky disease. C represents traditional neoadjuvant chemoradiotherapy followed by surgery, again within guidelines but no longer preferred. D is false. While she has rectosigmoid disease, her tumor is stated as arising below the peritoneal reflection and includes T4 disease with bulky lymph nodes. Thus, she's a candidate for trimodality rectal cancer therapy. So, thank you. Any questions?
Thank you, Dr. Baum. What's your experience with short course radiation followed by chemo and a non-operative approach? Is your institution promote that?
For full disclosure, Yale does not yet have a watch and wait program set up, which I think they need. So I have not been standard using that because I think you do need a reliable program in place with your surgical colleagues. As far as short course radiation and then chemotherapy, I also think it depends to a large extent on your radiation oncologist preference. Most of the radiation oncologists, the primary one I'm working with, seems to always recommend the long course, but I think that in the watch and wait studies and in OPRA, they use long course chemoradiation in both arms, but I think a lot of the watch and wait programs are going to be based more on the clinical CR and less on the radiation chosen. So in a center that does watch and wait, I would not think they would exclude short course radiation, but I have never used it for non-operative management.
So this is more a question for the audience. I feel like in the United States, nobody is doing watch and wait because our surgeons all want to operate, and the only people who do get a watch and wait are the ones who don't show up ever again.
It's not really watch.
You know what I mean?
That's just
so
wait.
I'm just curious, does anybody have a program in this room where their surgeons or their team is on board? So everybody needs to go to Memorial then, I guess.
No, I mean, I think the key is, I think that we do offer, so not with short course, right? So the thing with short course too is that you need to either go immediately to surgery or you need to wait a longer time period because the surgical complications about the timing around short course is really critical. And so, and I think one thing that kind of doesn't get discussed as much, and even Rapido with short course, there was sort of, if you look at the kind of subset analysis, there was sort of a more incomplete kind of TME rate in the short course arm. So it's very variable by institution, but we're certainly doing non-operative management with careful discussion with patients around still kind of no survival data, but are not doing it in the setting of short course, so only long course.
And I think from the surgeon I spoke to before I gave you this talk, I think their main concern is this balance between the timing, right? They want to operate after radiation with a long enough time for, the complete response, but without starting to get into fibrosis and other surgical complications. And then they also want to guarantee this circumferential resection margin is clear. And so if you're looking for any sort of non-operative management, they're going to be a lot more comfortable with the long course radiation and the chemotherapy in either sequence of those two.